The pharmacological list of agents capable of inducing aplastic anemia is extensive and spans several therapeutic categories. Chloramphenicol is historically the most notorious antibiotic offender and will be addressed in its own dedicated section. Sulfonamide antibiotics also carry risk. Gold salts, which were once a mainstay treatment for rheumatoid arthritis, can paradoxically cause life-threatening marrow failure in patients being treated for an autoimmune inflammatory condition, meaning the very therapy intended to help them could devastate their bone marrow instead. This is a striking and sobering irony in pharmacological history. Chlorpromazine, an antipsychotic medication, also appears on this list. This underscores a critically important point. Aplastic anemia risk is not confined to oncology or infectious disease pharmacology. It extends into psychiatric medicine as well, a fact that is easy to overlook. Various anti-inflammatory and antimalarial agents round out this category. Finally, alkylating agents used in cancer chemotherapy are also implicated. Their marrow suppressive effect is partly a predictable on-target toxicity. These drugs are designed to kill rapidly dividing cells, and bone marrow stem cells are among the most rapidly dividing in the body. This reinforces that the same mechanism used to eliminate tumor cells can simultaneously devastate the normal marrow stem cell compartment. Chloramphenicol deserves its own focused discussion because it produces bone marrow toxicity through two completely distinct mechanisms that must never be confused with one another. The first mechanism is predictable and dose-dependent. When chloramphenicol is administered, there is a pharmacological suppression of marrow function that is directly related to the amount of drug given. This is an expected, on-target side effect. Importantly, it is generally reversible. Once the drug is discontinued and levels fall, the marrow recovers. The second mechanism is entirely different in character. It is idiosyncratic, meaning it has absolutely no relationship to the dose given and cannot be anticipated based on how much drug the patient received. This reaction is unpredictable, severe, and frequently irreversible. It represents a rare but catastrophic individual susceptibility, something intrinsic to certain patients that makes their marrow respond to chloramphenicol with a fulminant and often fatal aplasia, regardless of dose. This distinction between predictable reversible suppression on one hand and idiosyncratic irreversible aplasia on the other is clinically essential. It explains why chloramphenicol carries serious safety warnings even at standard therapeutic doses, and why vigilant monitoring is required whenever this drug must be used. In the next video, we will talk about viral causes.